So how many people in here have diabetes themselves? Yeah, wow. So it's amazing to be here with you. And, you know, and just to think about how hard all of us work every day. How many people here, you know, are partners of people with diabetes? Yeah, some partners. Thank you so much. No one knows how hard your job is. So, and it's not your job, it's being with the person that you love, but I think we don't necessarily always appreciate that. And what about parents of people of any age of diabetes? Thank you so much as well. There are so many parents out there, I feel, who don't get thanked, and you kind of make us, you help us make our lives look a little easier. And then also, probably speaking maybe for some other patients here, I think like a lot of the time we're just so busy being diabetic that we sort of forget to thank you. So thank you to all of you and others in here who might do work in the field. They're CDEs or doctors or nurses or people who work in the field and industry. And also thank you for doing so incredibly much. You know, we got to work together even more collaboratively, and it's amazing to be here in community with you. So thank you so much. You know, the JDRF here in Michigan, Denise, Lala, everyone who is making this day come together. This day is legendary. What I've been able to see outside of this room and all of the different opportunities for us as patients to get smarter is incredible. Why I was asked to come talk about some of these things is because I get to run this team in San Francisco. We go all over the world, and I mentioned this. How many people were in the tech talk? A number of you were here. Yeah, so I was talking about that I got to do with Dr. Brannon and Dr. Hirsch and all these amazing leaders from industry. That's kind of what we do, is we follow what's happening in science and technology. And so I do get a lot of chances to do things like take things off label and all of that. And obviously anything I say, I don't have any medical training myself. So anything that I say, of course, is things that you should take and use with your healthcare teams or to parents and partners. Encourage the loved ones to do that. But the first... So the first thing, let's see if I can get this slide. Yeah, so one of the things that Dr. Hirsch talked about, and wasn't his talk amazing for those of you in here? I mean, incredible. He is legendary. And our team loves following him all over the world and looking at what he is saying and doing. And so one of the things he's been really talking a lot about time in range for many years, because we obviously know, you know, all three of these pie charts, they all are a 7 A1C. And, you know, like, I guess you could say, we know they're pretty, you know, we know that they're pretty different. We feel more or less productive depending on how well we're doing, how much time we're in range, and how much time we're hypoglycemic. And we are excited about all of the things that are being worked on to reduce hypoglycemia. And that's some of what I'm going to talk about. So this is, these are curves that some of you have been used to seeing over time. They're just glucose curves. And we know, like day 3, that's, you know, if you look at the different curves, you can see like some of these are miserable, especially the ones that have a lot of variability, and we know the ones with less variability are really good. I got to hear a good friend of Dr. Hirsch's speak not too long ago at the International Center for Diabetes in Minneapolis, and he was talking about something new that I had never heard, but it's called FNIR. And so FNIR, this is just flat, narrow, in range, you know. And I think as we as patients start to look at more of our data and we get to see more of it, we will get more of the sense of just trying to make it as flat as possible. That makes us, it makes us feel better, it makes us more productive, makes us do better, and of course, we know how important the dangers are of staying really away from hypoglycemia. So, you know, all the variability does make sense why we feel it when I think about a chart that a colleague of mine at the diaTribe Foundation. His name is Adam Brown. He put this graphic together. And how many people have read Adam Brown's work before? Maybe on diaTribe.org, a few of you. It's great. So JDRF has helped us bring today his book, Bright Spots and Landmines, and this is based on like 60,000 hours of using CGM. And his work on CGM has helped lead him to be able to have better time in range. But these are all of the different factors. And there might even be a few more, but a lot of these are really impossible to control. So, we, I think, as patients are like pretty hard on ourselves, you know, when we see a lot of variability. But I think, and Adam has made a big point about like a lot of this we really can't control. Earl talked this morning briefly about this meeting that happened in Berlin a couple of months ago. What was cool is at this meeting, when all of the luminaries meet, they are looking more for patient perspectives, which we think are great. And sometimes you hear a question about what's the patient perspective, you know, and obviously we know there's not just one, right? We know that depending on the amount of support that we have and depending on how much access we have to new technology and you know, how much support we have at work and things like that, maybe we have more access or less access, and maybe we can use more or less of it. But the cool thing was at this meeting, all of these academics came together to talk about what are the ranges that we're going to talk about being safe. So we mentioned Beyond A1C. That doesn't mean we're getting, you know, that as patients or as a movement, we don't want to use A1C. We just want to be able to contextualize it more easily and better. Earl and I have talked about quality of A1C for very many years, and we just want to basically make sure that patients have tools that can help them have better, higher quality A1Cs. So that's what a lot of that is about. And Dr. Gromberger, you know, from right here around Detroit, has been very instrumental in this movement as well. So has the JDRF new CEO, Aaron Kowalski. And I just also want to say, like, we owe so much to the JDRF just for getting CGM on the map way back in the day when it was like clunky to use at the beginning and it was not so easy. I think the JDRF really had the vision that using CGM becoming better, that was what was going to enable better time in range. We think one of the, I don't know, I guess sort of important frontiers to think about is other patient-reported outcomes also. So when new therapies or new technologies are going to be approved, we would also like, and this is some of the work that diaTribe is doing, we would also like other patient-reported outcomes to be considered. You know, so what are the tools that are going to come to us that will make us sleep better, that will make us less stressed, that will make our families less stressed? Things like that are really key, and that was also, you know, some of what I think the direction that the folks in Berlin were going. So I think it's also just really important to, you know, for me to acknowledge and thank as a patient, and I'm sure all of you patients feel this way too, and families. I mean, the JDRF continues all this incredible work on multiple cures for diabetes. That's not what my talk is about today, but I just want you to know, like, the progress is pretty amazing. And I know a lot of people have had experiences of being diagnosed and maybe they heard that a cure was coming soon. Did anyone here hear that when they were diagnosed many years ago? Yeah, some of you. And so definitely, I don't want to overstate, obviously there's a lot of important work that still has to be done. But some of the work that we get to go and hear about at scientific conferences on things like beta cell replacement, on immunology, the JDRF is doing amazing work there. And with this new CEO, and all of the CEOs have been incredible, but I think especially Aaron coming from this long history at JDRF, from working so hard on technology and then making sure you know, that we can use the technology to enable the best care that we can have, and to make sure that there is also, you know, a lot of understanding the advances on the cures front. And we don't even talk about a cure for type 1 diabetes anymore. We talk about multiple cures. There are multiple pathways for that. So let me just go to the, this is going to be a section where we talk a bit more about the therapies. Does anyone in here take it? Well, you might not want to say this, but I don't know. Any interest in or anyone taking an SGLT2? This is off-label. Yeah, I see some nods. Okay, good. So this is one thing that I'm going to focus on here. Insulin is a given. I loved hearing Earl talk today about smart insulin is still being worked on really hard at JDRF, and there are a lot of industry partners. Sanofi is a big one of them, and there are some other ones, Novo Nordisk, who are working on smart insulins. I'm really excited for that. But I'm also excited about knowing where can type 1s benefit from perhaps using therapies that have been created specifically for people with type 2. Which therapies, kind of deliver better outcomes for us, less burden. And it's all about, making better choices easier, right? And the science has been pretty transformative. We're doing really well as a field in terms of creating the science. I think maybe sometimes there's a bit of a lag on how long does it take to get to type 1, and so that's what I want to talk about. That's what I want to talk about here. So if it's approved in the US, and there aren't any SGLT2s inhibitor approved here yet, but that would be the first oral adjunct therapy for people with type 1, and I think it is pretty exciting. So this is a pill that would be taken once a day in addition to insulin, whether or not you're taking insulin by pump or pens, whatever. In really recent trials, you might have seen some of them, and it has been tested now pretty rigorously in type 1. The advantages, there's a bunch of them. One is, in many people, it tends to reduce hypoglycemia. They prompt weight loss rather than weight gain, like insulin does. They give time in range increases, and also something that Earl talked about earlier today. As type 1s, we really need to think a lot about heart health and make sure our blood pressure and cholesterol is as healthy as possible. The blood pressure outcomes for people taking SGLT2s have also been really good. And this is with no additional significant hypoglycemia risk. So a couple of these have even been approved in Europe. The way they work is pretty interesting. So our kidneys just absorb sugar in our urine. That increases our blood glucose levels. And for most people, that's okay and it's good. But if you have type 1, that means our blood sugar goes high, right? So the drug makes sure that we don't reabsorb the sugar. We simply pee it out. And the drug does raise the risk, the additional risk of ketoacidosis. This is super serious to realize, like the side effect profile of how the drug works. We have followed a bunch of different researchers and what they have said on this front, Earl Hirsch being one of them, Ann Peters from Los Angeles being another one that we've watched really closely, Rich Bergenstahl in Minneapolis. And they really do think that this risk is manageable. And I just want to read you maybe just a few things about what other type 1s have said who've taken this therapy. So they said it lowered insulin needs, stopped my roller coaster sugars, and lowered my A1C, expanded my time in range. Nice addition to insulin. I now can't live without supplementing injectable insulin. And by the way, the T1D Exchange, they do a lot of work with JDRF. They're also funded by the Helmsley Charitable Trust in New York, which has also been an amazing benefactor to JDRF. The T1D Exchange actually did come out with data not too long ago showing that a pretty high percentage of type 1s are really not at their glycemic target. Does anyone want to throw out what percentage of us as type 1s are at targets? Not you, but just the whole population of type 1s. And this was an estimate for the United States. What? 10%. It was a little higher than 10%, but not much. 80% of people with type 1 were not at their glycemic targets, despite the fact that we do have new technology. I mean, that we have ongoing technology that many of us have access to and all of that. So you're right on. So we need more help. So a couple of the other quotes. It is another helpful, easy-to-use tool in my diabetes toolbox. It seems to be working pretty well so far. I pretty much think it's a miracle drug, had a big difference in my A1C. So, you know, there are definitely precautions that have to be taken using this. This was something that we just created at diaTribe.org just to say, like, these are ways that you can take it more safely, and all of that is based on the experts. But, you know, I think that I mentioned this morning Jeff Hitchcock, the head of Children with Diabetes. He has something that he says, life is not lived off-label. So this is not something that JDRF is saying that anyone should do, but I'm saying specifically I think it's important for people with type 1 to know about alternatives and to work with your doctors on it. My doctor, Nancy Bohannon in San Francisco, has many people on this. You do have to make sure, if you look at this, so that you're working very closely with your doctors and that you're very committed to checking your ketone levels. So we have this infographic online. It's diaTribe.org/SGLT. The area continues to evolve, but I think it's fair to say that most of the experts would agree that type 1s are not doing well enough. Not as well as we could be doing anyway if we had if we had time, support to think about all of the things that Adam writes about in his book, which we have a bunch of copies out there for anyone who would like it. But he talks a lot about food and mindset and exercise, so it's not all about just a new therapy, and just one new therapy isn't going to do everything for you. But it is really interesting that this was a drug developed for type 2 that is helping a lot of people with type 1. It's also really interesting to know that in type 2, this is now viewed as this is a drug that has been seen in tests with thousands and thousands of people as being cardioprotective. So this protects people against heart disease. People who weren't taking it in the clinical trials had heart disease much, much later, and also kidney disease. And I remember when I tend to get all of this news really early in the morning. A lot of times it comes from Europe. And I remember the day when I saw that it was renal protective, protecting our kidneys. No one should have to have kidney disease. No one should have to have heart disease. But I remember I went up to my kids. They all share a bedroom, all three of them. And I was like, this is amazing to know, that many of us with diabetes will experience less disease if the right tests are done, of course, in type 1, if the type 1s are like this as well, that's not been established. But we found out that this was true for type 2 for millions of people. So there's a couple of them have been approved in Europe. The way they've done it in Europe is to make it approved for people over a certain BMI. I think a lot of that was just saying, let's test it in a smaller group of type 1s. And we think that's really good at diaTribe to do as well. I think that sometimes just opening up the floodgates and saying that everybody should use it, that might be kind of scary for FDA. It might be easy to be critical of FDA, but FDA is keeping us safe all the time. So, the US is a little slower on this right now, but we hope to see this therapy approved for type 2s as well. For type 1s as well in the US, like it is for type 2s all over the world. What else is there? So have people heard of Similan? Similan was approved many, many years ago. And so this is it's pramlintide. It's another hormone that has been shown to give help to people with type 1, but it's very, very, very hard to use. So some interesting work has been going on with different hormones, using some of these in automated delivery systems where they will be easier to use. And so we've heard some rumors that there will be more work done on this on the amylin analog side. Some doctors do think that is really one of the keys to kind of fully automating insulin delivery, meaning no meal counting or bolusing or kind of having to play around with the settings. I think the jury is still out on this, but there is a really interesting study in Canada where researchers were attaching 3 pumps to people for a couple of days just to see what the exact impact was from each of the hormones, and to see if working 3 hormones together could be useful. GLP-1 is another drug that is approved for type 2s in the United States. That also, it has been an injected therapy, and the first one was approved in about 2005. Type 2s were taking it twice a day. Then they got to once a day. That's called Victoza. Some type 1s take Victoza off-label and have had a lot of success with that. Then it got to once weekly, and now there's an even oral version of GLP-1. And the company said that it would start to work on testing this in type 1s again when it was an oral pill and when it would be easier for us to take. So there's also something called glucagon receptor agonist that has the potential to reduce DKA risk without increasing the risk of hypoglycemia. There is just a real burden that we see from taking insulin. And I think we forget it sometimes. Like, insulin is probably the hardest drug in the world to dose, and we just do it every day. Like, we just do our best with it, right? But you can see when insulin is automated that the needs for insulin change every single day. So even though, and hopefully you're lucky to have a healthcare provider, I hope everybody here has a healthcare provider that they feel is doing a lot for them, but it's way too much for us to expect all of them to be able to figure out exactly how much insulin we would need every day, because all of those needs change. And so some of those therapies I think will be able to help us. I want to just move now to talking a little bit more about CGM. I think the biggest pieces of CGM are, the on-body components are getting littler and littler, which is great. It's a little easier to wear CGM. It's getting easier to use, and even more importantly, it's getting less expensive. So these are kind of the pieces that we're focused on. These are just some pictures of where some of CGM is going, and we talked a little bit about these earlier, but it's going to be like a bandage like CGM, the G7, that is going to be the next Dexcom. That'll launch next year. That's in collaboration with Google. And I thought it was a big deal a few years ago when Google came into this. And it is definitely, diabetes is getting the attention of bigger technology companies. And I think that's a really great thing. So we've heard very good things about that collaboration. A lot of it is very under wraps. So we don't hear too much, but I think that's something to look out for. The Freestyle Libre 2, that's Abbott's next Freestyle Libre. This has alarms, and so the current one. How many people are familiar with the current Libre? This is, so a lot of you just a patch on your arm, and you wand it, and you can see how you're doing. And this has been very, very successful throughout Europe and now in the United States. And but many type 1s have said that they would like to have alarms attached to it. I actually got to use the next generation one. It's only available really right now in Germany, but that's an advance, and we certainly would expect it to come to the U.S. sometime soon. Medtronic hopes to have another improved CGM with calibration finger sticks only for one day. A lot of the advances in CGM have been going to no calibration. And then the implantable Eversense CGM that goes under the skin, that's right now available in the US. I've gotten to use it myself. Having something be implantable is pretty cool, like having the flexibility to take a CGM. There's a piece that goes over and you can take it off, and all of that. I think the whole thing with CGM, this is a tool for people to help figure out their time in range and how all of us can have closer to those flat lines. And so I love it that there are more, just that there are more options for CGM. And again, going back to really thank JDRF, I don't think we would have CGM available to nearly as many people if we hadn't have had the work of CGM, and also the fact that CGM is now available on Medicare is really a big deal. So I want to talk also a bit about pens and pumps and different delivery systems. So how many people here use pens? Yeah, or your loved ones uses pens. How many use pumps? Yeah, wow, this is amazing. And how many use CGM? Yeah, so a lot of people have access to these different things. I think it is really important to know, there are just a range of different ways of being able to take insulin successfully. But insulin, again, because it's such a hard drug to dose, I'm really excited about a lot of the work that has been done on the pen front. I'm not going to spend a huge amount of time on pens because it seemed like there were more people on on pumps, but we're going to be putting this, all of the details online on diaTribe.org, so you can go and see. But just to say, the manufacturers are really investing in better pens, and this is also so important for people with type 2. Some people with type 2 can be on pumps, but for many of them, they only need basal rates, and this is really important for all of us with diabetes, that all of us do better. So Companion is working on something new, and also it actually has a reusable Bluetooth-enabled pen that captures all that data. I can say, as someone who used pens for a while, sometimes you do just forget how much you have taken. So this whole piece about us knowing our numbers and knowing where we are is so big. So right now, this has been approved. It works with Novolog and Humalog. The median copay is $50, so this is also a really good option from the financial perspective. Bigfoot Biomedical might be most known for being run by Jeffrey Brewer. He's, of course, one of the former CEOs of JDRF, and he is amazing what he and the team is filled with people who have diabetes themselves and what they're making happen. So how many people have heard of Bigfoot Biomedical here? Some of you, yeah. This is a company, I mean, it doesn't have anything FDA approved yet, so it's not really out in the mainstream yet, but I think they are doing amazing work figuring out how to improve our lives by making everything easier to use together. So that might end up being insulin that's automated through a system with a pump and CGM. Also, they're working on pens. NovaPen 6, you can see that is a reusable insulin pen that tracks insulin doses. And this is only available in Europe right now. We don't know when it's going to come to the US, but I love seeing that there is much more investment on, I think, manufacturers' parts on more investment on making sure we have insulin. So there is more attention on access. We'd love to see the field work together even more on that. But also, like, once we have insulin, making sure that the field is really helping us focus on what is the right dose to take, and recognizing the complexities around that. And then common sensing GoCap, that's a reusable cap for disposable pens, and that connects to an app via Bluetooth. And that tracks all the stuff that we don't want to keep track of manually. That's like dose amount, the time, the units that are left in the pen, temperature, all of that. That still doesn't have a bolus calculator, but that would be the hope for people with type 1, because, again, just making things easier for us. And then Lilly has a smart pen that it's working on as well that's kind of based on the Quick Pen. I think that we also just wanted to really make clear that there are so many people also globally, that JDRF is helping. Pumps are by far the highest percentage of people with type 1 have them in the US, and many people globally don't have access to them. And we would also, as all of these algorithms become better, as the technology becomes better, we also want to make sure that many more people globally will also be helped by algorithms and software and all of that. I'm going to move now just to talk about automated insulin delivery, and just to say there is an explosion of growth going on here, and I love being able to use this because my insulin needs are so variable every day. Like, some days I take 20 units and some days I take 35 units. If I had to figure that out, I don't know what I would possibly do. It's not possible for a person to do it, or even a doctor to do it, nearly as much as for a machine to do it. And so then we get to work with our healthcare providers on all of the other pieces of diabetes that they can help us with. So just quickly, the Medtronic MiniMed 670G is on the left. Probably most people who use pumps know about it. Are there any 670G wearers in the room? A few of you, yeah. So this was kind of the first automated insulin delivery that the FDA approved, and Medtronic is already working like full speed ahead on other pumps that have even more improved algorithms and things like that. But the whole piece of this is just, it's CGM. The CGM measures your glucose, sends the information to sort of a mini computer. that mini computer is what calculates the dose. Then every 5 minutes, you're getting the insulin that you need. And sometimes it's just keeping insulin back, and that's a lot of the power of it. Right now, that's basal insulin. You still do have to give yourself corrections and bolus for meals, but that's available now for kids as young as 7. And then probably within the next year, children as young as 2 will be able to get it. On the right-hand side of the screen is Tandem's Basal IQ. There's amazing feedback coming out of Tandem as well. This is kind of this automated predictive low glucose suspense system. That one uses the G6 by Dexcom, which is the CGM that some people will want to stay on. Doesn't require any finger stick calibrations, and the concept of this is pretty simple. Just if the system thinks you're going to go low, it stops giving you insulin. And then there is a lot of excitement also about what is coming next. I already talked about Loop earlier today, and this is kind of like the community's response to, okay, there are pumps available, there's CGM, it's up to us to build the algorithms and all of that. And I think that, I think there are, well over 200,000 people on Medtronic and Tandem together. I think Loop is still probably about maybe 3,000 people, something like that. It does require you having someone in your life who can help you with some coding, et cetera. But this is the future. All of these things are making the coding easier is going to happen. And that has been amazing to see this emerge, because I do think it has moved the rest of the field probably more quickly. I use one with Omnipod, and I just wanted to show you the little piece that goes with it was made by, this is called a Riley link, and this is what is the interface between my Omnipod and my continuous monitor. I actually get to wear 3 continuous monitors at once because I'm seeing how close they are together, but this one in particular is run by Dexcom, and it is amazing to see. I just got it literally last weekend, and I mentioned in the last session, my time in range for the last couple of days is 95%. My time in range for the week, I haven't even had it for a week, is almost at 90%. And for me, some people can do that, with pumps, with pens, et cetera. For me, I haven't been able to get near that. So for me, to be able to have this be easier and better is pretty cool. I'm also really lucky that I have a doctor who believes in testing some of these systems, and that I also have I have a partner who does a lot of the harder coding work for me. I should just say also the fact that these are becoming more interoperable, that patients will be able to, choose more about which systems that they like better, is pretty cool. I guess the other thing that I would say is that there are all kinds of ways of doing better. Some people are also using inhaled insulin as corrections, or some people are using inhaled insulin as their bolus, things like that. One thing is funny, about Loop. The first 2 days, my numbers were at 99%. And actually, I had one day of 100%, which I think I've never had that before. And so then I was like, God, this is really magic. And it was midnight, and I was working at home, and the kids were asleep. And I was like, oh, I'm starving, and I got to stay up. I was actually finishing a medical school recommendation for one of our incredible associates, and it was due. It was actually due. What day is it? It was due last night at midnight, and I sent it in at about 8:55. But this was what I was working on late at night, and I go in front of the refrigerator, and I made that fatal mistake of opening the refrigerator, and there's a pizza box there, which we never have in our house. But the kids had come home late with my husband, and I'm just like, it's probably not an empty box, and I open it up. There's one piece of cheese pizza left. And I'm like, oh. And I have Loop, this fancy new system, and it's going to correct everything for me. I eat the pizza, and then I wake up at, 200. It's like, why am I 200? I thought I had this magic system. It's like, no, the system doesn't let you eat whatever you want. The system does things within reason, and it will certainly bring you down faster than you might otherwise. But just to say, I don't want to sound overly enthusiastic about it, but it just helps us be, it helps us be smarter. and so these are just some of the figures that you get to see. I don't think this is actually a real pointer, but you see the second graph from the bottom on the left-hand side. What's really cool about that is that's when I wasn't supposed to be taking insulin, and the system figured that out. But if I were just on Tresiba, which is an amazing basal insulin, but that is giving me a standardized linear dose, and it's pretty interesting to see that there's many places where you actually don't need to be, where you don't need insulin if you're type 1 and have a lot of variability. diaTribe.org/loop is just some stories of different people who have been able to use loop, and loop is just leading to many more systems that will be approved by the FDA. And again, thank you to JDRF for helping propel this and for helping work on it. These are some other options that are coming that I'm kind of referencing. So many people are using Loop if they want to be fully automated right now. But what's amazing to see, there's Control IQ from Tandem that is coming. That's going to be hopefully by the end of the year, and that'll do more than just basal doses, also bolus doses. They're studying this in kids. Omnipod Horizon, that is expected in the second half of 2020. That'll hopefully be down to age 2. And that's, again, your pump just talking to your G6 and helping you keep in closed loop. Medtronic's creating a next generation. That's called the 780G. That's expected right now by April 2020. That'll have Bluetooth for remote monitoring and software upgrades. And one of the pieces that I forgot to say about the Tandem that people are loving is that you can upgrade just by software, and the power of that, not having to get a new pump and deal with the copays and all that sort of stuff, is very powerful. So, and then there are some other ones that are a little newer. Tidepool I was talking about before, Beta Bionics. Beta Bionics, that pivotal study, that's bihormonal, so that's using insulin and glucagon, and that basically allows for a more aggressive algorithm. That's going to, that pivotal study is supposed to be late 2019, early 2020. Bigfoot Autonomy, I think that's such a cool name for a system. That consists of a pump, and that is the old Asante Snap pump and a newer version of Abbott's Freestyle Libre. And so an app on the phone will control this system, and that's expected to launch sometime after 2020. Again, that's run by the former JDRF CEO, Jeffrey Brewer, who is a major force, and I think is kind of in many ways prompting all of the manufacturers to invest more in this area. And then Lilly has jumped in. We don't know too much about what Lilly's doing because they're pretty good at staying stealth, but they're hoping to launch a system between 2020 and 21. That's the G6, the Dexcom G6, an app control, and kind of this puck-like pump that was designed by the inventor of Segway. Okay. I know that there are probably a bunch of people in here who have had problems with insulin sets over time. You should know there's a lot of innovation going on there as well, trying to make things better for you on the set front. And we're excited to also see the work on that so that there won't be as many occlusions and problems on that front. This is also cool to see that there is much more that is going to be happening on apps. And, there's a lot of discussion now probably that how many apps are there that are amazing, that have gone viral and all of that. But I think it's important to think we got to walk before we can run. But looking at the success, we've heard a lot of success on the Sugar IQ. That's really specifically available for people who use the Medtronic Guardian Connect. But that just looks for patterns in your blood sugar, and then it identifies, this is what happens to you on Saturdays. So your dosing might need to be a little bit different. And I think with that knowledge that we're doing so much, people with diabetes, that we probably wouldn't notice these patterns that something was happening every Saturday or something was happening nights between 9 and 11. With that knowledge, then you can keep an eye out more for that. That is going to make us smarter. They also have something kind of a meal assist function, and that helps you keep track of just a handful of meals, not every meal, but what does happen? you know, when I'm eating something that is higher fat? What is happening when I'm you know, when I'm eating ice cream, as an example, something super high fat, that can be managed better. We're so far from the days. I was getting to talk to this amazing advocate this morning who was telling me about when she was diagnosed decades ago. I mean, you just couldn't have any sugar at all because you just stayed away from it, and that was just the rule. Some of our shirts at diaTribe, the back of them say, actually, I can eat that. You know, we don't need to go crazy, but knowing how to manage meals and being able to use technology is really powerful. So, so I really like that. Sugar IQ also has something that is pretty amazing. It can forecast hypoglycemia that's coming, and so actually then that lets you kind of act in the moment to be able to prevent hypo. The new Senseonics CGM also has something that identifies pretty far ahead of time hypoglycemia that is coming, which has been amazing to see. So we write about all of these things in diaTribe, and we just want to say thank you so much for coming here to listen, for your participation, and really for the big honor to speak with you all. This is what we work on at diaTribe, which is education. Our newsletter is actually now once a week, comes out at the end of almost every week. We work on education, and if you want to be on a Type 1 list, just let me know. My contact information is at the end of this. We even have one newsletter that's a little, it's not, we actually haven't, it's not on the website or anything like that you can sign up for, but if you let us know, we send you extra relevant news to people with Type 1, and then we just work on connecting. So we have about 185,000 people who get the newsletter now, and have had over 2 million people on our website in the last year, and that keeps growing, and largely through our partnerships with JDRF. The JDRF has also given diaTribe a lot of visibility, so we thank you guys so much for that. Just one more shout out for Adam Brown. We have books outside for you. Even if you have one, maybe you'll take another one and give it to someone else with diabetes. He wrote this amazing book. He just basically invented time to do it because I kept saying, you've been so successful with your diabetes in so many ways, and how have you done that? And he's used largely CGM to help make him smarter. But this book is all about the things around the products as well. So how does he manage to be smart about food? How does he think about exercise, mindset, sleep? He was diagnosed when he was 10. He went through this whole period that he's very open about when diabetes was much harder for him, but super open, honest, and direct. The book, I think, now has sold almost 150,000 copies. It's $5.80 on Amazon. That is exactly what it costs us to produce the book, and none of the money comes back to diaTribe, but we just try to make it as widely available to everyone. He also has an audio version that's free download, and then you can just download the PDF free online as well. But I would love it if you could spread the word about the book if you find it to be helpful. And it's, again, diatribe.org/brightspots is where a little bit more information is online about it. How many people in the room have seen the book before, Adam's book? Yeah, oh, so great. So a few of you raise your hands. I hope that you'll take a copy outside, and thank you to JDRF for making it possible to have these. This is just a quick look. This is our teams at Close Concerns and at diaTribe and at DQ&A. Some of you might fill out information at DQ&A. That is what helps diaTribe basically commission data and things like that that we can take to FDA to show how all patients are doing. That's just a little picture of my family, and if you have any reason that you would like to contact me, if diaTribe can help you, if we can help point you in the direction of better education, please let me know. And thank you so much again for the honor of being here and speaking with you. Thank you.